prevent, I guess the mistakes of the past. That's a bit of a cliche, but we'll try to go down that road. So the way emergent pathogens kind of evolve, it is very difficult to assign causality. Typically the way it unfolds in the field is you may be a practitioner who is submitting samples to the diagnostic lab, and you rule everything out, and you're left with really no answers on your case, and suddenly somebody comes up with a potential virus or a bacteria that they found in the case, and you latch onto it and say, yes, we found the answer to this case. Or you could be sitting as an audience in a talk like this one, and I could give a case report type presentation and stand up and say, look at this virus I found in this set of tissues. And we all go home and say, yes, we found the answer to this disease that we have, and we think that that's causality. But I think we are all told in vet school, and sometimes forget it, that presence of an organism in tissues or is association. That is certainly not causality. And as Tom mentioned, I was involved in the discovery of PCV2 back in the mid-1990s. And we made a lot of mistakes in that time, and it was a very challenging time assigning causality, and circovirus, as you know, is not the simplest pathogen to deal with. So in retrospect, I think we could have done things differently, and ironically, some of the issues that we're dealing with today in the industry, maybe with circovirus type 3 or with rotavirus B and rotavirus C, we're falling into the same mistakes that we made 30 years ago. So I think the overall purpose of my presentation is to try to look at causality in a bit of a different way, so that when you, sitting in the audience, have the researcher stand up and say, I found this virus in this tissue, you maybe would then say, well, look, that's fine, but there may be 9 or 10 other things we need to know before we just assume that that's a causal organism. And we can put that into practice. So to begin with, let's review a little bit about the discovery of PMWS, now known as PCV-AD. So this was my role back in 1994, 96. I was a young practitioner, had a lot more hair and fewer gray. Saw an outbreak of wasting disease, jaundice pigs in kind of the late nursery, early grower phase in a 600 sow farrow to finish farm in Saskatchewan. And what was interesting about this farm was it was extremely isolated. And in Western Canadian standards, what that means is there are no other pigs within 5 miles of this particular farm. It was a production nucleus, so it had very, very tight biosecurity. And not just lip service to biosecurity, it was very tight biosecurity because it was a production nucleus operation. And I went through this outbreak, and you can see in the epidemic curve there in the top right of mortality, unexplained mortality. Pigs dying of pneumonia, they're wasting away, they're turning yellow. The herd was PRRS free at the time, and I've said many times, if we had PRRS in this herd, I probably would have just said, oh, this is PRRS, interesting, and away we go. But it was PRRS negative. And we really did not know anything about what this outbreak was caused by. And it wasn't until late 1996, so really about the tail end of the curve here when things were going back to normal, that Ted Clark, my collaborator, he's the pathologist. So I'm the clinician at the farm, and I characterize what we're seeing clinically. And I'm sending samples off to Saskatoon from all these dead pigs, hundreds and hundreds of dead pigs out of this farm. Ted Clark is my collaborator, pathologist at USask, who is characterizing the pathology. And together, then, we were putting this together. And it was kind of at the end of the outbreak, when things were finally getting better, that Ted, through his contacts through the pathologist world, came up with the possibility that maybe this was circovirus. So there's that first association with PCV2 and PMWS, 24 months into this outbreak. So over the next 6 months or so, that connection was made a little bit firmer, and other researchers got involved. And one of those researchers was Debbie Haynes, who was an immunologist, and her specialty at that time was developing immunohistochemistry assays, and they were very popular at that point in time in terms of diagnostics. So they made an IHC test for PCV2 and started to use that in looking at retrospective investigations. So in 1991, there was another case in northeast Saskatchewan, and if I said the first herd was isolated, this farm was even more isolated. So it's about a 40 sow operation, small Mennonite family, and located in northeast Saskatchewan. And if any of you guys are hunters, you're probably up in this area. There are more moose per acre in this area than there are pigs per acre. That tells you how isolated this site actually is. And for some reason, it had gone through a very similar outbreak of wasting. The diagnostic investigation team, which was multifaceted, went up, and they had no idea what it was caused by, and it went away. And ironically, when the immunohistochemistry test came out and it became available, they retrospectively identified circovirus in the tissues of these pigs from that farm. So this is the true index case of PCV2 in Canada, not necessarily the one that I worked up. And these are typical lesions. You've probably all seen these lesions from over the years, and some of these are from the very index cases. So the reason I like showing the kidneys are those are age-matched kidneys from late nursery pigs, in the 8 to 10 week of age. And the very first lesion that was kind of a significant event for circovirus that I found in October 1994 was a kidney that looked like that. And we had sent that in to the pathologist at the time, and I think the pig also had ascarids, so he chased the ascarids and said, that's a really interesting kidney, I have no idea what that is. But anyway, that was the first lesion that we found. So, interstitial nephritis, bottom left-hand side here, picture of the internal organs from a jaundiced pig, and you can see the liver there, which is yellow and atrophied down. So end-stage liver. That is a very highly prognostic of death because they don't recover from that. Lots of interstitial pneumonias. They're present in the center. Some of them are bronchial pneumonias as well. And on the top and bottom right, what I'm trying to show there is the effect on the lymphoid system. So we have lymphoid depletion histologically on the bottom as a lymph node or a spleen. And then the top, we have a picture of the thorax, which is opened up. And within that circle, you can see the heart. And what normally is covering the heart is the thymus. And in this case, we have complete thymic depletion in a very young aged pig. So again, very just typical lesions of circovirus, just to make sure everybody's aware of those. So in terms of PCV2 and the pathway to causality, there are different things that we had done, and we thought we were doing a very good job in putting all of our, ducks in a row. So Ted Clark and I then spent a couple of years describing the clinical signs and the pathology of the syndrome, and we had called this PMWS because it was descriptive of what we were seeing. It was post-weaning, and the pigs were, wasting, and there was many different organ systems involved, so hence post-weaning multisystemic wasting syndrome. We didn't know what it was caused by, but we thought that was a very descriptive name. John Ellis and group, then he's a virologist at USask, and his colleagues then, identified circovirus. The milestone was their ability to culture the virus. That came kind of in that 96, 97 period. So they identified the lesions and identified circovirus in the lesions after the immunohistochemistry test was available. They reproduced the lesions in notobiotic pigs. And that's an interesting story, and John will say that that's a serendipitous event. They experimentally reproduced it using both tissue homogenates from affected pigs as well as cultured virus. And the story apparently goes, just as we were ready to submit this manuscript, they got the results back for other viruses that they needed to confirm, and lo and behold, those pigs had parvovirus infection as well. So that's where this link to circovirus and parvovirus initially came up, was because it was a serendipitous event and completely unexpected. In retrospect, without parvovirus, probably the lesions would not have been reproduced, and they would have moved on and said this isn't circovirus infection. So very, very important event. But again, co-infection, that doesn't necessarily, it's not necessarily good enough. So Gordon Allen, shortly after that, did a study. He's an Irish researcher, and he had just completed a PhD in circovirus type 1, so he was primed and ready to go with circovirus type 2. And he then did a co-infection model, some with, some without circovirus and parvovirus. And again, he showed that if you co-infected pigs with both, they got sick. And if they're infected with one or the other by themselves, then they didn't get very sick. Steve Sorden was a pathologist who had worked in Saskatoon during the outbreak in the mid-90s and then had since moved to Iowa State University for a stint. He developed the first case definition, and we'll talk about that in a minute here. And then Kim Segales, many will know Kim from Spain, had reconfirmed that case definition shortly after that. And then another milestone event in this discovery was Steve Krakoka's work at the Ohio State University, where he reproduced lesions of PMWS, or wasting syndrome, in notobiotic pigs, but only with circovirus, but he needed an immune stimulant to induce the disease. So again, circovirus needs something else to induce that disease, but at least he did it only with circovirus. And then, ironically, we changed the name to PCV-AD, but that was really 10 years after the initial discovery of PMWS or PCV2. So just a reminder for those who are not familiar with the case definition, that there are 3 criteria that are required to fulfill and diagnose PCV2 or PCAV-AD in a set of tissues or a group of animals. And those are, we need clinical signs that are characteristic, we need histologic lesions, and there are 2 histologic lesions that are important. One is lymphoid depletion, and the other is granulomatous inflammation. So it's basically lymphoid depletion in the lymphoid organs, may be accompanied by granulomatous infection, but in the non-lymphoid organs, you're going to need to see granulomatous infection. And then thirdly, we need to see or identify the virus within those affected lesions. And that's either by immunohistochemistry or in situ hybridization, or EM. So for those new practitioners that are out here, PCR is not on this list. So if you're going out to the farm and you are using PCR to diagnose PCV2 on a farm, you're not really following the case definition. So be very careful in how you interpret that. And I still get calls today with somebody who's gone out, done a bunch of PCR on sow bloods or on tissues or on grow finish serum. They say, that's fine, but you just wasted a couple $100 of the producer's money, because that is really useless. So just be aware of that. Okay, so where did the controversy really start from? And we started to see, I would say, most European countries, which, France was very heavily affected, and PMWS was blowing through Europe at this point in time. So the Europeans were largely on board with PMWS and the association with circovirus. Asia was coming on board. They were starting to see some lesions, and they're craving for information. So they were pretty happy to accept that there is a relationship here, and they accepted the pathway to causation that we had come up with. The controversy really was in America, some degree in Canada, but really the big problem was in North America. And it started really before that, and the quotes that I'm showing here is actually from England. So Mike Muirhead is a fairly renowned veterinarian from England, and he wrote in the Pig Letter in 1999, a word of caution. Don't jump the gun, as we did with PRRS, and claim that EMC virus was the cause. So I don't know if you know the history of EMC, but in the late 80s, mystery disease was a big issue here, and there are a lot of speculation about what the cause of mystery disease was at the time. And a group of researchers here at the University of Minnesota came up with EMC virus as a potential cause, made a bunch of autogenous vaccine, took it out to farms, and very shortly after that, the whole story changed because the Lillestad Institute discovered PRRS, then shortly after in North America, here at the university as well. So that's what that refers to. Don't make a mistake and lead people down the path when you haven't proven the causation model. We need to be very careful, controlled studies both on and off the farm, and don't forget to fulfill Koch's postulates. Okay, so very good words of wisdom. Let's not assume causality. Let's make sure we have fulfilled Koch's postulates. The controversy grew. Okay, so here's a quote. In my experience, when I see the occasional PMWS-like lesions, the group is usually going through episodes of acute PRRS. Once the PRRS is brought under control, I don't see animals with PMWS-like lesions. This may be a bit simplistic, and I'm not trying to blame everything on PRRS. Rather, what I'm suggesting is that PMWS is usually associated with herds and regions where the pathogen levels are high. And that's an interesting quote, and that certainly is correct when you look at regions in Europe that we're breaking down with PMWS. Completely inaccurate when you look at the 2 index farms that are in isolated locations in the middle of nowhere and very high health farms. No PRRS up in those locations. This researcher went on, and you can see the astounding Carlos Pijuan, a very esteemed researcher here. I'm getting a little bit tired of all these pompous syndromes that help little to understand the underlying disease. I'd like to propose that we change the name PMWS to dirty pig syndrome, something that is easier to understand and gives us an idea where the problem truly lies. So I'm not bringing this up to criticize Carlos, but I think Carlos really hit the nerve that a lot of people felt in North America at the time, that we had gone miserably wrong in our causation proof, and people just were not on side. So why is that? Well, I think in this period of time, in the late or the mid-1990s through to early 2000s, there were not a lot of PCV2 outbreaks in North America. Apart from the cluster of farms that I was dealing with in Western Canada, there really weren't a lot of farms breaking down in Eastern Canada or much of the US. At that time, there was intensive industry focus on PRRS. It was early 1990s when it was discovered. Vaccines had just come out in the, I guess 1993, 1994, in that period, if I'm not mistaken. There is kind of effort in getting it under control, maybe some early movement in regional eradication, regional control. But the world was PRRS at that point in time in North America. In the causation model, we talked about this whole PRRS, or the circovirus, parvovirus connection. Circovirus needs something else to induce disease. And we call that, circovirus is a necessary but insufficient pathogen. And I think there's a lot of discomfort that we still have about pathogens like that. So when I teach basic undergraduate disease courses, circovirus is the last one I teach, because I think intuitively we want to say, okay, you infect a pig with a pathogen and it gets sick most of the time. But here you're saying you're infecting a pig with a pathogen, but we need to do something else to that pathogen to get it going. And there's some discomfort with this whole necessary but insufficient disease. And then I think in some ways, there's a lot of debate on whether, in fact, we had fulfilled Koch's postulates. And with that, let's delve into Koch's postulates. So, 1885, Robert Koch, a German scientist, came up with 3 postulates, and there's either 3 or 4, depending on the translation. So they were written in German and have since been paraphrased and translated into other languages. And those postulates were built on really some concepts that his supervisor came up with back 40 years prior to that, around 1840. So Jacob Henle. So hence they're called the Henle-Koch postulates. And there's 3 underlying postulates that we need to be aware of. One is, the parasite or the infection occurs in every case of the disease in question and under circumstances which can account for the pathologic changes and clinical course. So, okay, we have a pathogen that's causing the disease or associated with the disease. The pathogen can occur in no other disease as a fortuitous or non-pathologic parasite. And after being fully isolated from the body and repeatedly grown in pure culture, it can induce the disease anew. So pretty straightforward. We typically do remember those. But we got a problem. Okay, one is the second one. Koch's postulates do not account for subclinical diseases. If you put the pathogen in the animal, it needs to develop disease. So any subclinical disease we deal with today does not fulfill Koch's postulates. Secondly, the whole point of growing pure in culture really was akin to the 1880s, and we did not have viral cultures or tissue cell lines at that point in time. So that meant an amorphous agar-based culture medium that you can grow bacteria on. And that's not the case. So technically, PCV2 cannot be grown in pure culture under the real technical explanations of Koch's postulate, and it cannot induce a disease anew because it needs something else to stimulate it. It needs that co-infection. It's a necessary but insufficient cause. So PCV2 technically fails the Henle-Koch postulates. So what's the problem with them? Well, they predate the discovery of viruses and prions, doesn't account for subclinical diseases. You can't use them if you have a non-culturable virus, such as rotavirus B, rotavirus C, PCV3. Doesn't work for chronic incubation periods like Creutzfeldt-Jakob disease. Doesn't deal with necessary but insufficient causes. And it certainly doesn't deal with oncogenic viruses. So the Henle-Koch postulates are problematic. And even at the time that they were discovered in 1885, Koch himself admitted that there were times when these postulates are really not feasible. They don't really work. So the point of the Koch postulates are really that they fulfill disease causation on a conceptual basis, not necessarily on a rigorous basis. And they are certainly open to subjectivity and interpretation. So there are alternative postulates that we can use. We learn about these in some advanced epidemiology courses, but we pretty quickly forget about those as we get into the field. So there are postulates for viral diseases, for chronic diseases, those using epidemiologic criteria. There's postulates for necessary but insufficient agents, postulates for using immunologic concepts, slow neurotrophic infections, and then obviously the molecular guidelines because we're now in the molecular age. But when we talk in meetings or hear researchers present, we don't hear anything about these alternative postulates that we really should be when we're trying to assign causation to some of these emerging pathogens. So there is one set of postulates that does stand out in my mind, and I've read most of these, and I think if I could make one suggestion or one lesson learned out of all of this 30 years later, I would say that we should be looking seriously at something called the unifying concept. And it was written by Alfred Evans many years ago, 1976, and if I'd known this back in the mid-1990s, it would have made things a lot easier. It obviously considers the pathogen effect on the animal, which is good, but it also encompasses epidemiologic and immunologic and microbiologic evidence as well. So we're dealing with populations here, and I think we need to deal with both the individual animal and its effect on the population. And this set of postulates is also compatible with sequence-based evidence, which is what we're typically dealing with today. So we'll just go through these very quickly. The first criteria then talks about the prevalence. So the prevalence of disease must be higher in the infected than the non-infected. That makes sense. The exposure to the pathogen must be higher in the diseased animals than the non-diseased animals. That makes sense as well. The incidence of the disease must be significantly higher when animals are exposed to the putative pathogen. That makes sense. Temporally, it makes sense as well that you must infect before you see clinical disease, and those responses in the animal then follow a biologic gradient from mild to severe, which is related to the dose of the pathogen. So all that makes perfect sense. Sixth, you must have a measurable host response. So if you infect, there should be an antibody response. Okay, that makes sense. You should be able to experimentally infect, but and when you do, the animals that are infected should have a higher incidence of disease, so that makes sense. But we're not just limited to experimental infections in the lab. That could be done in volunteers or in the laboratory or natural exposure on a farm as well. If you eliminate the putative cause, the disease incidence or severity should decrease. That makes sense. And if you modify the host response, i.e. you vaccinate, then you should reduce the incidence of disease as well. And then finally, the whole thing should make biological sense. So where do we sit with PCV2? And the controversy in North America really ended when PCV2 vaccines came out. And that was the final step, and that's one of the 10 criteria here that you vaccinate and the disease incidence decreases. So I think we have fulfilled everything with PCV2 now. my question is, what about PCV3? What about rotavirus B and C? What about those pathogens? So has anybody stood up and kind of said, how many of these criteria do those pathogens actually meet? And kind of what's the strength of association and strength of causality here? So I think somebody needs to do the hard work down the road then to investigate those pathogens. So if I was to make a couple of conclusions, it would be, don't forget that association does not imply causality. So the next time you hear of a researcher stand up and say, I found this virus in these tissues, you should say, whoa, that's just one. We have 9 more criteria that we need to fulfill. Okay? The power of the Cox postulates really come not from their rigid application, but from the spirit of scientific rigor that they foster. So the next time somebody says to you, have you fulfilled Cox postulates, you should say, no, but that's really not feasible today anyway. So there are alternatives that we should be looking at. There are many alternatives out there. Because we live in a world of population medicine, I think we really need to look at both what's happening in the animal and tissues as well as what's happening epidemiologically and immunologically and microbiologically. And I think of the postulates that are out there, I think the unifying concept is really the one that moving forward we should kind of wrap around and try to run with, because I think it'll do us a lot of good in the field. With that, I'd like to acknowledge, this is Yang Yun Wong, my former PhD student who kind of got on this trail of causation on a more practical sense when we were doing our work with peri-wean fail-to-thrive syndrome back maybe 10 years ago. And there are a bunch of references. If you're interested in reading up on any of this stuff, please come and see me. So thank you very much.
Thank you, Dr. Harding. Any questions in the room right now? Go ahead.
I'm a simple geneticist, sorry. Where did the disease come from in the end? You mentioned something northern Manitoba where it manifested first.
Yeah, I think the virus was widespread across the world. So I don't think it's where PCV2 came from. I think it's what is the inducing factor, the agent X or whatever it is that came in and induced all these outbreaks. And we really don't know, and there probably are multiple agent X's that kind of came through at the various times. But, the virus was widespread.
So as a practitioner, how would you advise that we interpret results or requests when clients are interested in looking for PCV3 or other non-rigorously tested diseases that they feel may be an implication, or if you find those when you're doing a very broad, diagnostic overview?
Yeah, so I guess my first kind of comment on that is don't go looking for PCV3 unless you know what to do with the results. That's the first thing. And the second thing is there is enough literature now that would certainly point PCV3 into being more highly associated with some lesions and not other lesions. So I don't believe PCV3 is causing everything out there. So just because you find it, I would absolutely not say that PCV3 is the cause. So become familiar with the literature on what PCV3 is really associated with, and target your diagnostics accordingly. And if you do get a result that PCV3 was found in a tissue of something, but it doesn't match the literature of what really the strong association is, then I would say we have a virus circulating that's likely not causing disease. So, I believe that PCV3 probably is inducing some disease, but probably 10% of what people say it is.
And what about sapovirus cases if you find it and everything else is negative or really inconclusive?
Yeah, so there's a really nice paper on sapovirus where the group from Iowa State actually did do some of this epidemiologic work, looking at the differences in, I guess, prevalence of the virus in diseased and non-diseased, as well as animals from different farms. So I'd encourage you to kind of look at that literature as well. And again, it's very specific. And I think, you know, if I was a younger practitioner now in your shoes, what I would do is get out the unifying concept and check off how many you think we have fulfilled in that box. And I'd also encourage researchers to do that as well. So if you are an expert in an area, you know, of emerging pathogen, check off how many have we really fulfilled here. And I think over time, the body of evidence will certainly point into a stronger likelihood of causality. But in the early days, I don't think we're there. So be familiar with the literature, understand the unifying concepts and how to use them. I think that'll help you guide on the farm. And, you know, as much as anything else, be a very skeptical veterinarian when you hear researchers getting really excited about finding something new, especially when we're in this molecular sequencing age and we've got nanopore sequencing out. We're going to find viruses left, right, and center. That doesn't mean they're all causal, though.
Thank you.
Thank you, Dr. Harding.
Thank you.